Hello, good day. What's up mga ka-inmates? Today, our group will have a very quick and simple overview about the upper limbs, mainly your shoulders and your arm. We will try to make human anatomy more easy and simple to understand. First, this is your human body. So this is your anterior view, and this is your posterior view. So first, we will discuss the simple things or simple parts of your arm and shoulder, and also some of their clinical notes. Here, you see your axillary part. This is your axillary part. That is your armpit. The other part is here. One of its clinical notes is that it's the most common site for intramuscular injection. The next thing is this imaginary groove here. It's also quite visible, but the thing about this groove is this separates your biceps brachii and your triceps brachii. The next thing is about this. This is your medial condyle. We just call it MC. One thing important about this is here, your ulnar nerve passes. Your pectoral girdle, it is composed of your sternum, specifically the manubrium part, because here there's your whole, this is your sternum as a whole. This is just a small thing, the mandibular parts, in which your clavicle will connect. Your clavicle is also connected into your acromion of your scapula. I just want you to imagine, there's always this connection, or what you call joints that connects these things, these three main parts. Here just imagine that is your shoulder joint. Simply it connects this part of your body to your shoulders. And also this part of your joint connects this part of your joint into this part of your body. And also this is your wrist joint. So we call it wrist joint. This is your elbow joint. This is your shoulder joint. So now let us discuss the skeletal system, mainly on your upper limb. First things first, we'd like to discuss about the clavicle. This is your sternum. And here is your manubrium part where your clavicle connects. So this is your clavicle, this is your acromion part of your scapula. By the way, this whole thing is your scapula. I would like to discuss and to point out that if you will look from here, that is your superior view, your clavicle would look smooth. But if you look inferiorly, it would look rough. So why rough? It's because below there's a lot of grooves that would make an articulation for a lot of ligaments, muscles. Example, there is your conoid tubercle, which connects to your conoid ligament for trapezius muscle. It's a clavian groove. An important impression I would like to note is your costoclavicular ligaments. It's for articulation of your ribs. So your clavicle has your sternal end. From a word sternal end, it connects to your manubrium of your sternum. And your acromial end, that connects to your acromion of your scapula. So one thing I would like to discuss to you, it's part of your medial half. One very important thing to remember is the medial half is convex anteriorly. Your lateral half is concave anteriorly. One clinical importance is this. Your clavicle is easily be fractured. It's because in this medial half, it has its weakest point. Scapula is also called shoulder blade and resides over the posterior surface from ribs 2 to 7. Basic part to remember is your glenohumeral joint. So this is your glenoid fossa, where your humerus will be connected. In clinical term, it has a term of glenohumeral joint that connects your humerus to your scapula. Next is your acromial end. Like I told you, your acromion will be connected to your clavicle. That is your acromial joint, which is also called your acromioclavicular joint. Lastly, thing too important is your glenoid fossa. The whole thing is your glenoid fossa. This is your acromion, where your clavicle would connect, and your coracoid process, that would be a connection to your pectoralis minor. You can see here the spine. Important significance is that the spine divides your infraspinous from your supraspinous. Above it is your supraspinous. Below it is your infraspinous. Your supraspinous simply connects to your supraspinatus muscle. Your infraspinous also connects to your infraspinatus muscle. So in your scapula, if your serratus anterior, which is innervated by your long thoracic nerve, may be pressed, may cause the winging of your scapula. As you can see, here there is this thing, that's the scapula is not in place. Proximal. And on your proximal side, you may see its head that faces medially upwards and backwards. So that's the head of your humerus. So next thing I would like to discuss is the neck that separates the greater and lesser tuberosity. So the question is, where is your greater and lesser tuberosity? This is your greater and this is your lesser tubercle. Your greater tubercle is put it. GT is that site for attachment of your rotator cuff. It may involve your supraspinatus, infraspinatus, and your teres minor. So this is your lesser neck. So it's a site for your suprascapularis. So your surgical neck is located somewhere here. Surgical neck is frequently fractured by direct blow. Its risk may include damage to your axillary nerve, axillary nerve, and your posterior circumflex artery. Should the shock or the body? So this is the long one. The body is a site for deltoid tuberosity. This is your tuberosity that would connect to your deltoid muscle. Fracture include the damage to your radial nerve, which controls the extensor muscles of wrist and may cause sensory loss, and also aside from your radial nerve, profunda brachii artery may be damaged. And the distal part is your lateral epicondyle protuberance, lateral to your capitulum. So you have your medial condyle for flexor muscle and capitulum for articulation of your radius. So this is your capitulum part. So this is your ulnar side, and this is your radial side. So your radial side is connected to your capitulum. So this is your capitulum. And also in your ulnar side, this is your trochlea. Trochlea. Your shoulder area contains muscle connecting to your scapula and humerus. So these muscles are the deltoid, supraspinatus, infraspinatus, teres major, teres minor, and your subscapularis. These muscles are responsible for free rotational movement of your shoulder joint. So in general, axillary nerve supplies your deltoid, teres minor, suprascapular nerve also supplies your supraspinatus, infraspinatus, and the subscapular nerve supplies your teres major and your subcapsularis. So first, we would like to locate your deltoid muscle. So I would like to repeat, your deltoid muscle is also common site for your injection. So your deltoid muscle originates from your clavicles. It inserts into the lateral shaft of your humerus. Imagine this is your humerus and its lateral side. Just imagine it's connected there. So it is an adductor, extensor, and also a rotator of your arm. Your supraspinatus muscle. So review lang. So this is your spine, which separates your supraspinatus muscle here, and here is your infraspinatus muscle. Your supraspinatus muscle originates from your supraspinatus fossa of the scapula and inserts to the greater tuberosity of humerus. So it abducts the arm and stabilizes shoulder joint. Next is your infraspinatus muscle. It originates from infraspinous fossa of the scapula and inserts into the greater tuberosity of your humerus. It laterally rotates the arm and it is the stabilizer of the shoulder joint. So next is your teres major. So here is your teres major. And here, that small muscle here is your teres minor. So your teres muscle originates from lateral border of your scapula and then inserts to your greater tuberosity of the humerus. It laterally rotates the arm and is a stabilizer of your shoulder joint. I would like to add the location of your subcapularis muscle. Originates from your humerus. Here is your humerus. And inserts to the lesser tuberosity of your humerus. It medially rotates the arm and stabilizes the shoulder joint. The stabilizer of the shoulder joint, mainly subscapularis, supraspinatus, infraspinatus, and teres minor muscles have tendons that compose of rotator cuff. Wear and tear of these tendons result to a shoulder pain known as the rotator cuff tendonitis. Degenerative changes of the subacromial bursae may lead to a condition known as pericapsulitis. In advanced tendinitis, these tendons may calcify and rupture, and the patient will be unable to initiate abduction of the arm. So let's go now to the upper portion of your arm. So your upper portion of your arm is subdivided into anterior and posterior facial compartment by its medial and lateral facial septa, which contain all muscles, nerves, and arteries. The muscles in the anterior fossa compartment are the brachial brachii, your coracobrachialis, and your brachialis muscle. So in general, all these anterior compartments are supplied by your musculocutaneous nerve. So let us now discuss these muscles and their action and their clinical significance. Biceps brachii. It is the supinator of the arm and the flexor of the joint and the elbow joint. It is supplied by the musculocutaneous nerves. Musculocutaneous, let's just put them in there. This muscle has a long head and a short head. The short head is attached to the coracoid process of the scapula, and the tendon of the long head of this muscle is attached to the supraglenoid tubercle of the scapula. This joint is usually affected by osteoarthritis in some individuals. So this is your coracobrachialis muscle on the right part. So it originates from your coracoid process, as you can see here. Coracoid brachialis. It is attached to the medial shaft of your humerus. This is the medial shaft of your humerus. So it is a flexor of the arm and it's also a weak adductor. Next is your brachialis muscle. It originates from the lower half of your humerus. This is your humerus, that is your lower half. and is attached to the coronary process of the ulna. It is a flexor of your elbow. The muscle of the posterior facial compartment are the three heads of the triceps muscle. In general, these muscles are supplied by radial nerve. So next is your triceps muscle. This is composed of three heads, a long and a lateral and a medial head. The long head originates from the infraglenoid tubercle, the scapula. The lateral originates from the upper half of the posterior surface of the shaft of the humerus, and the medial head originates from the lower half of this. These three are attached to the ulceron process of the ulna and serve as extensor of your elbow. Lastly, we would like to show you and proceed to the blood supply, mainly your artery, veins, and your lymph nodes. So, first, we would like to discuss about the artery. So, you have here the axillary artery. Your axillary artery comes from your subclavian artery. So, it just becomes an axillary artery if it passes below your clavicle. Then, it will proceed further to the humerus part, is this brachial artery. So, this is your brachial artery. And then, it will bifurcate into the radial artery, this thing, and also this thing. That's your ulnar artery. In additional notes, there is this highest thoracic artery, or your superior thoracic artery, which is here, the one in color. So it is a small artery that runs around the border of your pectoralis minor. So next is your thoracic artery. But most important thing here is this. A lot of bifurcation comes from here. So this is the thoracoacromial artery. Immediately divides into terminal branches. So this are the following terminal branches. The clavicular branch of the thoracoacromial artery. It has its deltoid branch. One I mentioned earlier is the lateral thoracic artery. So this is the lateral thoracic artery, which runs along the lower border of the pectoralis minor. One last thing I would like to show importance is the anterior and posterior circumflexumoral artery. So this is the anterior circumflexumoral artery, and this is the posterior circumflex artery. So you also have your axillary vein, as well as your axillary artery. I would like to discuss here the veins and its tributaries and its connection. So here you have your cephalic vein. You just put it there for a better view. That's your cephalic vein. So it's also a site where you get your venipuncture, but it's not the first choice. Later we will know what's the first choice and why. So this is your axillary vein. So this will turn out to be your basilic vein, and it's also a site for your venipuncture. So these are your median vein. It's also called your median antebrachial vein. So here, it is really important to note that most medtechs prefer to get blood from here. It's because it's immovable. Sometimes, it is not clearly visible for the medtechs or for the doctor. So you may use your cephalic and basilic vein. Your lymphatics. Clinical notes about lymphatics is that some conditions called axillary lymphadenopathy. It is the enlargement of the axillary lymph nodes. So these are your lymph nodes in your axilla. Common causes include infection of the upper limb, resulting in inflammation of your lymphatic vessels with tender, enlarged lymph nodes. Humoral group of lymph nodes is usually affected first, and red, warmer, and tender streaks are visible in the skin of the upper limb. Infections of the pectoral region, and metastasis of breast cancer. So axillary lymph node dissection. So it is the removal and analysis of the axillary lymph nodes is often a vital tool for staging breast cancers. Interruptions of lymphatic drainage for the upper limb can however result to lymphedema, a condition whereby accumulated lymph in subcutaneous tissue leads to painful swelling of upper limb. During this procedure, there is also risk of damage to either lateral thoracic nerve or your thoracodorsal nerve, causing your winged scapula. Your long thoracic nerve will cause the winging of scapula. This is all mga ka-inmates. So hope you learned something from our small discussion. Please stay at home, stay safe. So God bless mga ka-inmates. Goodbye.